Good afternoon. My name is Captain Andrew Kale. I'm the Medical Operations Planner for the Multinational Joint Task Force. Today I'm going to be briefing you on a proposed course of action in terms of implementing global health engagements for Sector 4. Sector 4 mostly includes the country of Niger and our partner forces within the Armed Forces of Niger, but to the south of Niger is northern Nigeria, and to the east of Niger is Chad. While we have been engaged in the region for over the past 2 decades, and in 2015 we started this multinational joint task force, we're still struggling with controlling Boko Haram and Ansaru. These two insurgents groups create significant havoc and chaos for us in terms of engaging the civilian population and winning over their trust. We're hoping through global health engagements we can have a more persistent presence with the civilian population outside of combat operations. Both Boko Haram and Ansura present significant challenges to us. Most recently, they have tried to gain influence with local village leaders by promising to improve healthcare delivery. Although our intelligence has not shown that they've been able to fulfill their promise, this remains a significant threat. We are also stretched thin with our medical resources as our op tempo has increased within the AO. The global health engagements that will be proposed will take these into consideration and provide a path forward. The overall objective for our proposed course of action is to create internal capacity for partner forces to carry out global health engagement, military, civilian activities. The proposed course of action includes 2 primary tasks. The first task is to provide annual flu vaccinations, and the second task, which is more of a long-term goal, is to conduct maternal child wellness clinics quarterly within the region. The proposed course of action supports all echelons of objectives from the combatant commander down to the task force level. The purpose of the 2 GHEs are to create a persistent medical support presence in the area with clear time marks for engagement. In particular, the annual flu vaccination will allow us to have a reason to be doing GHEs on an annual basis. The maternal child health clinics will allow us the opportunity to engage with the most vulnerable of populations, women and children within the area. This allows us to have direct influence with these populations who we would normally not be engaged with outside of a combat operation. This also allows us to engage with the youngest of the population to help to shape their perceptions of our partner forces as well as the US before the insurgency can shape their ideas about us. The flu clinics can easily be done with personnel who are already in theater. This does not require a high level of engagement from clinical personnel, as non-clinical individuals can be trained to give vaccinations and do the initial screening. The more challenging aspect of this course of action would be fielding teams who can do the maternal child health clinics. This again would not necessarily require privileged providers, but could be done by public health nurses who have specific training with maternal and child health monitoring. These teams could be fielded from outside of the theater on small TDY engagements, or if this was more of a persistent presence, we could look at students in the Uniform Services University programs and align their curriculum with doing 2 to 3 week engagements within Sector 4. In terms of funding, we'd likely be looking at ODECA funding as well as humanitarian and civic assistance funding. These funding streams would be through the U.S. Department of State and could possibly include PEPFAR money as well. For these COAs to be successful, we would need the Joint Task Force surgeon to be on board. We would also need buy-in from the DOS military attaché, and then whatever partner agencies we decide to field the maternal child health teams from. This may be from Landstuhl or from the Uniform Services University. In terms of basic assessment, monitoring, and evaluation plan for the flu vaccination, this would be easy. This would be the number of vaccinated broken down by age and sex. And if we did vaccinations for both partner forces as well as civilians, we would want a breakdown of that as well. For the maternal child health clinics, this would be number seen, what the issues were, and then longitudinally do these issues shift. Presumptively, if we found a cluster of issues within a village or one or two primary issues within a village, we would want to work with that village to address those issues, so the next time or the next year the team was around, we would see that the issue was no longer of significance. Sector 4 mostly includes the country of Niger and our partner forces within the armed forces of Niger, but to the south of Niger is northern Nigeria, and to the east of Niger is Chad. In conclusion, with these proposed courses of action, the annual vaccination clinic as well as quarterly maternal child health wellness clinics hope to do is to provide healthcare services that are meaningful within the region and have a high impact in terms of building trust between the partner forces, us, and the civilian populations. Where these clinics would take place would be where there are great concentrations of the local population within the DIFA region. However, we would likely want to stay away from large cities, as we would not be able to support these populations in significant numbers.